Welcome, everyone. I'm Barb Kulis. I'm the Regional Stroke Education Coordinator. Steph is my co-host. He's the Regional Stroke Program Director for Central South. And it is my pleasure today to welcome Dr. Vince DePaul. He has been a friend and colleague to the Central South Stroke Network for many years, and we've called on him quite a few times, some of them recently, to present for us. So we're really pleased to know him. Dr. DePaul is an assistant professor in the School of Rehab Therapy at Queen's University in Kingston, Ontario. He conducts research in the Motor Performance Lab at Queen's University, and through collaborations with researchers and frontline clinicians in Kingston, Southeastern Ontario, Hamilton, Toronto, and Waterloo, Ontario. His research focuses on the development, testing, and translation of interventions for the recovery of walking in individuals with stroke, other neurological conditions, and in older adult populations. And his work specifically explores how individuals optimally learn and relearn gait and balance related skills, and how therapeutic strategies such as instruction, feedback, guidance, and supervised and unsupervised practice impact motor learning. Today, we welcome Vince to talk about ataxia following posterior circulation stroke. And this is the last in our 6-part series on posterior circulation stroke. So perhaps it's going to be the best of the 6, no pressure.
No pressure.
Welcome.
Okay, thank you. Well, thank you, Barb, and thank you, Steph. It's nice, always nice to, even if I'm not in Hamilton, to connect with the Hamilton group. I wasn't able to attend all the sessions, but it's been an impressive lecture series. So I really congratulate the network for putting this on. So as Barb said, we're going to talk about ataxia following posterior circulation stroke. Certainly, if you have any questions, you can post them, and I'll try and monitor the chat, but perhaps Barb and Steph can let me know if there's something that we can pause the slides to discuss. So as I said, this is just one among a series of talks, and I recommend, if you haven't been to them, they're all available and recorded on the website. So starting with more from a medical perspective and identification and diagnosis, and medical management, including rehab medicine. And then also some really nice information about some of the sequelae after stroke, after posterior stroke, including dysphagia and the visual presentations and dizziness. So today we are talking about ataxia. So just 3 sort of overarching objectives will hopefully you'll be able to gain knowledge related to and build on what knowledge you already have related to the understanding the clinical presentation and the rehab implications of ataxia. Also provide an overview of approaches to assessment. Again, some of this may be review for some, but also I'll introduce some outcome measures that maybe you aren't as familiar with. And finally, we'll talk about management and intervention strategies, again, touching on what's in the literature and what seems to be emerging in terms of some management techniques. So ataxia is from the Greek term lack of order, so which really is a nice description of what we see and what patients experience when they have ataxia. Now, ataxia can be categorized also by its cause or origin. So we can have sensory ataxia, or also sometimes known as proprioceptive ataxia, which is, as it says, ataxia, this disordered movement that's rooted in a lack of sensation. So it may be absent sensation in hemiplegia, or a specific type of stroke, not posterior, say a leukemia stroke or something like that, where you actually have a clumsy hand, that kind of thing, where you may be related to the sensory input. We have the cerebellar ataxia, which we're going to spend most of our time talking about today, and also vestibular ataxia associated with the vestibular system. So as I said, we'll focus on cerebellar ataxia today. So just before we get into it, it's helpful to remember what the role of the cerebellum is. So it's although it's a smaller part of our brain, it does a lot, and it has lots of responsibilities. And most of the tracks and networks go through the cerebellum, and we have to remember that, and that's why it's so core to moving and among other things. So it's responsible for initiation of movement in a timely and coordinated manner. So it's also responsible for, related to that initiation, it's the feed forward movement control. So based on every time we move, and in a typical neurological system, we gather information and we store that information about how things went, what did we hit the target, what did it feel like, and we use that learning for the next time we reach or walk or do whatever movement it is. So that's feed forward movement control, where it sends the motor program and it makes it happen. So that's rooted in the cerebellum. The cerebellum was also the timekeeper of movement. The timing of the movement between different parts of a limb, between different parts of the body, with time over the course of movement. So the cerebellum is tasked with trying to keep things on time and regular. Related to that, the cerebellum is essential for coordination of single and multiple joint movements. We've known this for a long time, or it's been identified that cerebellum is core to the coordination. More recently, there's a subtle sort of addition to this understanding. It's not just coordination of the actual initiation and the running of movements, but also it seems to be the coordinator of the acquisition of the sensory data. So it's pulling together and ensuring all the sensory input from our eyes, from proprioception, is coming together and interpreted, and that's how we then organize coordinated movement control. So although we have the sensory cortex is where the input is directly, the cerebellum is that coordinator of the sensory information coming in. And it's also, cerebellum has a big role in learning. So learning motor skills, which is really what we're all about in rehab. So if somebody has a cerebellar lesion, we have to remember that and think about how it's impact their ability to learn, or their time that it may take them to learn a certain motor skill. So in cerebellar, it's also important, although we're going to be speaking mostly about the motor features of the cerebellar dysfunction, cerebellar syndrome has both motor and non-motor features. So non-motor symptoms are, and this is increasingly being acknowledged, that there's language, so not just the production of sound and getting our mouth around words, but actual linguistic components. There's cognitive. So again, because it is the station and the things pass through it from all parts of the brain, You're seeing even cognitive impacts of a cerebellar lesion, and affective function, so mood and those elements we can see in people with cerebellar dysfunction. But again, we're going to focus on the motor. So just lastly, sort of just getting around the categorization, we can also think about cerebellar syndrome in terms of what its onset is. So acute onset, where the symptoms last, a number of last hours or days or weeks, or it can be chronic, but it's of a sudden onset. Sorry, I see your hand, Amelia. Sorry, I thought I saw somebody raise their hand. Then you can have chronic or permanent changes, or often progressive. So this is, so the first category is really what we're talking about today, is cerebellar stroke, that posterior stroke, whether it's ischemic or hemorrhagic. But then when we look at the literature in terms of understanding what the cerebellum does, but also about how to treat it, much of the work is also in conditions like hereditary ataxias, people with MS, with cerebellar affected. So though presentation may look very similar to what we see in cerebellar strokes, but it's the course of the condition is different. And then recurrent attacks, which are not as common, but these brief attacks that come in and resolve, and it can be from a number of sources, including vestibular can trigger some of these, the presentation that we see in that. So again, we're going to be thinking mostly about that first category. So again, this is probably some review for you, but these are some of the best words to learn when you're learning neurology, and I'm a physio and teach in the physio program, and so sorry, yeah. So I will provide the slides we'll be posting them on the website, and there'll be, of course, there's a recording as well. So as soon as we finish, we'll Barb and Steph will post those. So in terms of some of the things we see with cerebellar syndrome from a motor perspective, dyssynergia. So that relates to that movement performed in a sequence of component parts rather than, so that coordination of movement. And it's choppy, it's not synergistic, it's dyssynergistic, and it's not smooth. Dysdiadochokinesia is we'll talk about how we test some of these, but that's the impaired ability to perform rapid alternating movements. So just being able to do something like this, or doing the front back, this is being able to perform that over a period of time, or we typically look at 10 seconds and see how can a person perform the task, as well as sustain these rapid changes in direction, use of agonist and antagonist muscle groups, and switching back and forth, and people have difficulty with that. Dysrhythmia, so again, abnormal rhythm and timing of movements. Delayed reaction time, so related to that role of cerebellum in terms of initiation of movement. So people with cerebellar syndrome can take longer to get movement going, and then it's more uncoordinated once it gets going. Hypotonia. So this is a little more subtle in our physical assessment, but people can present with decreased muscle tone, and it can be hard sometimes to detect just by moving somebody through passive range, but we can see it often in by doing pendular reflex, so tapping their knee, hanging over the edge of the bed, and you see this exaggerated movement because of the lower tone. So the reflex is still there, but it's the tone isn't there to resist the movement. So dysmetria, so making errors in the length of movements. So you can have hypermetria or hypometria. So you see this example of trying to get to the pen, which you see some of the next one, which is intention tremor. So at the end of trying to hit the target, you see this intention tremor and this oscillatory movement, but you also can actually miss the pen or undershoot and then have to extend to get it. So this is what she seems to be doing: finishes early and then finishes the movement. Postural tremor, so it can be the whole body, but it's often if you're having somebody hold a position against gravity, you see an oscillatory movement. So them trying to control the movement and make corrections and turning on and off those muscle groups to do this, hold it steady. So you see this tremor. So how these are good to check, these assessments, and these sort of features, but it's most important to think about how they affect function. So we'll start with thinking about reach and grasp, and then we'll look at gait and posture. So the implications to reach and grasp, certainly we see people present as and even complain or report clumsiness when it's milder, and it's more apparent with a more severe case just by observation. When we think about what's required for a reaching and grasping or going to pick up a cup and bring it up to your mouth, there's three components to that task. So the transport, so the movement of the hand through the air towards the object. Grasp formation, so you actually, while you're moving, it's opening your hand or shaping the fingers depending on what the object looks like in order to grasp the cup or the ball. And then the grip, so being able to grade on, off, or scale up or down the amount of grip you need that's appropriate to actually pick the object up and hold it and move it. And those are dependent on what we know, and this is again, this feed forward control based on what that object is. If I know it's it looks like a slippery surface, I'm going to grip it harder. I have a guess at how heavy it is. I can see how big it is, and we've all been in a situation where if you pick up say a foam weight and you think it's heavy and you overshoot because it's when you go and bring it up, you've sort of, your brain has been tricked to believe it requires more activation than it did. Well, somebody with cerebellar syndrome that would be happening all the time, misjudging the amount of control you need. So that was thinking about those three elements of the reach. So again, with somebody with ataxia, the dysmetria and the decomposition of the movement, that breaking down of that smooth movement into parts, and tremor may impact the reach and grasp performance and success. So there'd be exaggerated path. So instead of a straight line, there'd be you maybe have a larger arc. There'd be corrections along the way. It'd be slower typically, or variable speed. So fast and slow, trying to get to the target. With the grasp, we typically see a larger opening the hand more than they need in order to hit the target. Multiple attempts, The other consideration, which we won't talk a lot about, but a core deficit or that we see in people with cerebral dysfunction is ocular motor. So what is happening at the eyes? So you can see people with nystagmus, so the oscillation of the eyeball, unable to track visually, you can maybe track, but you can't do it smoothly. So you get this jerky movement in your eyes. So all of that, of course, is going to impact our ability to identify where a target is and reach for that target and complete the task. So on top of the motor control elements at the limb, we also have this visual element. And that's particularly important for reaching, certainly important for walking, but it's reach and grasp, of course, is dependent on being able to see the environment if you rely on vision. I'm just seeing a message from Marcia that says, like, okay, great. Hopefully everybody else can see these slides. I've lost the audience. So this was just an experimental demonstration of what we've just seen in terms of what we see clinically. So in this task, in this setup, the researchers put markers on the person's hand, and also on their hand to be able to identify the size of the grasp, as well as on the arm and the wrist to quantify the velocity of the movement. So while they're moving through space. So on the right hand side of this screen, you see the V and the D. So velocity, and then this is the grasp, the distance between the thumb and the index finger. So I see a couple of people have raised a couple of hands. Any questions? Kyla?
Vince, I don't see any questions in the Q&A right now.
Okay, I just keep seeing somebody, it's, I guess I get this sign, it says raised hand. And so
I see that too, Vince. If people have a question, if you want to put it in the Q&A or the chat, if Vince doesn't see it first, I can address it, and we can either unmute you or just read your question out loud.
Great. Thank you. And maybe we'll continue, and then, yeah, if there's we'll take a little break in the middle. So you see this curve on the right-hand side. This is for a control or a neurotypical population on the right-hand side. So this is the top graph is showing the speed of the movement, the velocity of the movement. So when of this reach, so you see this high velocity initially, and then it slows down as the person approaches the target, which is this black box here. And that's pretty smooth, and this is repetitions over a number of repetitions, so it's pretty consistent over time. And then this bottom one is, again, the distance between the thumb and the index finger, so how wide they moved in order to hit the target. So they start closed, it opens, and then it comes to about halfway closed in order to actually put their hand on the target. So this is a patient with ataxia, with cerebellar dysfunction. So you see this difference in terms of so they start, they move relatively quickly, they slow down, they move, they speed up again, and it's not that nice, clean, sharp peak that you see, and it basically they're continuing to alter their speed right up until the time they hit the object. And similarly, they open their hand, they close it, they open it again, you get this double peak here. There's some consistency between trials, but there is still more variability than we see in the neurotypical group. So it's just a nice sort of depiction in a lab-based setting, but you can see how, picking up something like a cup of coffee in a styrofoam cup, where they have to guess at all those parts, or they're trying to control all those movements getting to the cup, but also control the amount of grip. So it can, of course, be disabling functionally, but also safety risks and things like that. So then thinking about moving on from the arm and the hand to the trunk and gait. So postural ataxia or truncal ataxia, this unstable stance, oscillations can be in sitting, particularly unsupported, depending on the level of severity, and of course in standing, this sort of constant sway or trying to correct and overcorrect. Wide-based stance, this is typically associated with midline lesions of the cerebellar structures. So where the sort of which serves the truncal muscles and so you can see it exaggerated there. Titubation, this again an oscillation of the head, can be the trunk, and it's this correct and overcorrect and trying to always hit the right spot. And then Ataxia gait, so that wide-based irregular steps, the regular step width, the regular step length, slowed. People are co-contract, so they trying to, often it's trying to hold their balance. So it's like if you were to try and walk on a tightrope, that's not the, I'm trying to think of the lines that people practice in the park, and so I would be turning everything on to try and maintain my balance and not doing a very good job. But well, that's the what people experience with cerebellar ataxia. And also people will, depending on where the lesion is, they will lean one way, or they may be, you might find them forward because the tendency would be to fall backwards, so they're overcorrecting forward. You can see them back on their heels when they're walking. So most of their weight is on their heels, so they're bringing their trunk forward to counterbalance themselves. Let's see what happens here. Okay. So I won't just have time, I won't show this, but I will include, I'll refer to these videos later as well. This is a video of somebody walking with cerebellar ataxia, and there's a series of videos that are actually posted on Twitter from I think her name is Emma G. She's an occupational therapist who had a stroke, a cerebellar stroke, and she's sort of documenting her experience over time, and I'd recommend checking her site. And there's some nice examples of her really working hard, and it's been a number of years, and some of the deficits she still has. So thinking about gait now. So this is just a review of the gait cycle. So when we think about what's happening with walking, we can do observational gait analysis. So we're seeing when the person, the starred leg hits the ground, so that initial contact, they take the weight through the loading response, then they bring the swing leg through, and then just before they lift that right leg off, it's pre-swing, and they've already taken weight on that left leg, and then they swing it through. So at each of these, there's, in typical populations, there's some variability between people, but there's a pretty standard gait cycle, and we see certain movements at each joint, and we would expect to see them consistently across repeated trials, repeated walks, but also repeated gait cycles. So this is one cycle repeated as we walk over ground. So with the ankle, we see this again. You see this initial, when the person is first hitting the ground, they're in dorsiflexion. The toe is pulled up towards their knee. Then they lower the toe down to sort of ease them onto the ground. See this plantar flexion. Then it goes up again as you bring the body over the foot and you go into more dorsiflexion, so that you see that leg behind, and until finally they do this push off and you see the plantar flexion again, and then it's basically neutral when they're swinging. So with some dorsiflexion to clear it. So that's a smooth line, and that's a typical pattern we see with people. So then when we see, this is a measurement from somebody with ataxia. So you see, instead of this smooth line, each line represents one gait cycle. So if I walk 10 meters, I'm going to have probably 20 gait cycles, and so you'll see each step is variable. So it's generally follows the path, but it's lots of variability in terms of where the joint is and what's happening. And this is just similarly when we look at the knee, the hip, the trunk, and also the pressure we're putting through the foot. There's this on the right-hand side, there's the typical, and this is somebody with ataxia. So again, just a better close-up of that difference. So this is that pattern we saw in the initial slide, and this is this variability, and again, for the trunk. So because of this, so you see this variability, and variability comes at a cost. So we move consistently, and people, when you see these neurotypical gait patterns, there's a reason why they're nice and clean, and there's some variability, but there's not a lot. It's because it's efficient, and our body adapts to walk with the most efficient pattern we can, so that we can go farther. So this is, we assume that it's, we know that stroke gait, like hemiplegic gait, is inefficient as well. So people use high amounts of energy to walk. This study looked at comparing cerebellar stroke to hemispheric stroke. So how do people with cerebellar dysfunction and ataxia walk, and compared to hemispheric stroke, so hemiplegia? Not how they move, but the energy they take to walk. So this group of patients walked just over ground for 6 minutes. They measured the distance they walk and their walking speed, but also their primary outcome was this VO2 measure. So they wore this device which collected their exhalations, and it gives you a measure of how much energy you're using. So they found that the energy costs of the people with ataxia were 30 to 40% higher than the people with hemiplegia. So as hard as the hemispheric stroke, the person with hemispheric stroke are doing it, working, many people with cerebellar stroke are working even harder. So, and we also found that the severity of the ataxia was highly correlated with the energy cost. So the more severe the ataxia, the more cost dependent or costly it is. So the impact of this certainly is us thinking about interventions and what people are doing throughout their day, and also the need for people to be have some cardiovascular fitness. So perhaps targeting that as a goal and a element of our interventions. I'll just mention this, freezing the degrees of freedom. That's what this, basically that walking and trying to limit the movements that at each joint. When we are skilled at something, we can loosen our joints and move freely, although still consistently. But when we're learning or when we have deficit like a cerebellar stroke, we freeze up our joints and freeze the knee and freeze the hip. So we're trying to control and reduce these degrees of freedom, is what we call, in order to cope. So I think again of me trying to learn how to ski, I'm basically freezing my degrees of freedom, among other things I'm freezing, to be able to try and get down that hill when I first learned. So, so how do we assess these things? So, again, these are, I won't go through all of them because I think these will be familiar with them, but this is you'll have this in your slides, just the different actual tests that you can get at to try and get at some of the impairments we see. So finger to nose. I think just one message that sometimes we can forget when we're doing these tests is we want to do them consistently. We want to, knowing that it's difficult for people to hit a target, particularly towards their end of their range. We don't want to do this too close. I've seen it done by even experienced physicians where it's quite close and you're doing this finger to nose test. But if we really want to challenge the person, it should be more open out in the open space. So the rule of thumb is about 90% of their range. So you don't want to have to lean their trunk, but you want to challenge them by extending that arm out. This is just an example of, for handwriting, you can do, again, a functional test and have them draw within this spiral and time the task, measure the number of times they cross the line, as a way to measure performance over or response to medication or response or recovery over time. So heel to shin test from the lower extremity, just checking muscle tone, but again, probably the knee jerk pendular test is a little bit more helpful than just, I would always do some passive movement of the joints, but you might not feel, it's hard to feel the subtle changes in the tone that way. And then again, remembering the oculomotor impacts of somebody with cerebellar involvement, as well as the speech deficits. I just share this, and again, you'll have this website for reference. It's a really nice, if you haven't seen it before, it's a nice library of videos of neurological exam of people with different conditions, and they have a nice section on coordination disorders, so you can see that. Okay, so in addition to just our standard clinical assessments, it's important to use standardized measures to sort of track change over time, see how people are doing at the beginning of rehab compared to the end. And this population, we know that having ataxia increases the likelihood of exceeding your length of stay by 2.5 times. So people often leave rehab with deficits, depending on the severity of the initial condition. So often are needed to be followed in the community or in outpatient services. So it's good to be able to track, document where they're at in hospital and on discharge and at different points in their care. So there's ataxia specific outcome measures there that you may be aware of. So the SARA scale, so the scale for the assessment and rating of ataxia. the International Cooperative Ataxia Rating Scale, the ICARS, which is, I think, been around the longest of these three scales, and it's the longest scale. So it's out of 100, takes about 30 minutes to complete. And then the brief Ataxia Rating Scale was developed based on the ICARS, so a briefer version of that. This is too small for you to see, but it gives you an idea of the areas that it's tested. So this brief, the brief Ataxia Rating Scale includes both Gait, so a score out of 8. So you'd score person once on Gait. So these aren't 8 individual items, but it's what level of walking from normal to walking is impossible with one accompanying person. So that if the person needs 2-person assist, then they would get an 8. Knee to tibia or heel to shin test, finger to nose test. There's a scale included for dysarthria, mostly observational. And then this is unique between the SARA and the brief Ataxia Rating Scale because it includes some sectional and oculomotor abnormalities. Only 2 of the total 30 points, but it still is there. So the more common that I'm seeing is the scale, the SARA scale, and I'm seeing it some clinically, but also in studies looking at evaluating the impact of interventions using the SARA. So there's 8 domains with different scoring for each. These are just 2. So I'm showing you the gait and the fast alternating hand movements. So it's, if we think back to those tests we do, the finger to nose, the rapid alternating movements for dysdiadochokinesia, these are nice because they also put a score to it. So it's not just qualitative and descriptive. You can actually pull this and use it in your charting to put a number to it. And they've established cutoffs for people in terms of the need for a walking aid. So again, this is out of 40. So you see, doesn't take much to for the cutoff is quite low to say that a person requires a walker. So at 12.25 or above, most of these people would need walkers. And this is, again, you'll find people who score this, but who do well without, but as a ballpark. As well, they've done the same for ADL dependence. So from mild dependent to max dependence, having some windows of scores that you see. So it's a nice way to communicate with, say, as you're referring to other programs, or again, monitoring people over time. There's been a number of studies looking at this tool in terms of showing it's reliable as well as valid when compared to other tools. The Barthel, it shows validity. So as the Barthel goes up, the SARA goes down. So a more severe patient would have a higher SARA score, which is the flip of the Barthel index. It's responsive, so it detects, it's been shown to be able to detect changes in people with cerebellar stroke, so improvements, but also in non-stroke related ataxia, it's be able to detect deterioration. And also there was a study by Yamaguchi showing that a score on the SARA is predictive at day 7 is predictive of the recovery that they'll have at 3 months. So there's this predictive validity around. So in addition to these specific measures, there's certainly generic measures that you can in your toolkit and you can reach back and use. Just think about when you're doing that. So these are examples, and you'll have your own examples that you use. But there's some that would not be appropriate or would be less appropriate. So I'm thinking the stroke master impairment measures. So it would be a less appropriate tool to measure the impairments in the upper extremity related to ataxia. You'd see people sort of ceiling out, or they'd be in the 6 range, because it's all about speed. And the Stroke-Master impairment scale was really based on hemiplegic patients and spasticity and tone, and you don't see that same presentation in this population. Okay, so getting into some interventions. So first, I've just said that we still, the dominant approach and the most evidence-based approach is certainly task-oriented training when we think about stroke rehab. And it's incorporated into a number of other approaches, including NDT. Certainly task-oriented is a core part of these. So it's acknowledged that this is still what we should be doing with patients, including patients with cerebellar ataxia. However, there's some specific sort of modifications when we're thinking about patients with cerebellar ataxia. So we still want to encourage high repetition, so people can learn, and they may need higher numbers of repetitions and more time to learn, but certainly they need the practice to learn. We need to, again, similarly practice, choose activities and objects and tools that are meaningful to the patient. You can see why when we look at how people have to be able to adjust their reach and their grasp and in a particular way to suit the particular object. So it's really important to choose objects that are relevant to what they're going to be using when they go home or within the rehab center, rather than abstract objects or just reaching into space. So be intentional when determining the parameters of practice. So when you think about exercise, we think about the FIT principle, the frequency, intensity, time. And so this is, we can maybe think about it as tasks. So we have to consider the timing of what we're practicing. So the timing requirements, do they need to go fast or slow? The coordination of the timing, the reaction time, do we want them to start and reach on command to get at that initiation? The accuracy, what sensory inputs, so we can adjust or understand what sensory requirements of the task, and how do they do when you change those sensory inputs, whether it's dim the lights or the texture or moving through water versus air, that kind of thing. So stability, the stability requirements, the consistency, again, we have to think about moving from trial to trial to trial. Are they consistent? And we're measuring that. And the complexity. Be intentional about when you're providing feedback, which is always the case, but also the amount of physical guidance or support. And we'll talk about this in a bit, but there's people with cerebellar ataxia, particularly postural control, will take what assistance you'll give them, because it can be terrifying to be so off balance. So often grabbing a bar or your hand or the family member's hand. And so just thinking about what they're learning when we're doing this, and this is certainly maybe required for safety, but if we are providing that guidance, that's what they're learning when they're walking and moving, be able to move with that amount of support. So being conscious of that. Structure the environment to balance the success that the person has, but also with safety. And also knowing we need to challenge in order to learn. So it's that, again, that fine balance of not discouraging people too much and keeping people safe, but moving them forward toward their goals. And then again, and related to what we just talked about, consider the energy demands of practice, and think about building fitness level through using a bike or ergometer as part of their rehab. So these are just some principles related to balance training that can be applied to particularly to people with cerebellar stroke. So moving from a wide base, which is more stable, to more narrow, static postures, so maintaining your balance versus keeping your balance while you're moving, slow movements, which is easier for people with cerebellum issues, to more fast and timed movements. Perturbation is anything, whether it's internal. So if I raise my hand, that's a perturbation. It disrupts my balance, and we can manage that. But somebody with cerebellum dysfunction that actually may throw them backwards, right? So try beginning with small amounts of perturbation, internal perturbations, so the ones they generate themselves by movements, turning their head, reaching, to external perturbations. So again, having us give a bit of a nudge, having somebody walk past them, those types of things. And then predictable to unpredictable. So giving them notice when you're going to nudge them, to unpredictable, having them not know. So that sort of is a nice way to grade up and down your interventions. And then adding dual task and related to that, a manipulation task. So carrying an object. When we walk, we don't typically just walk. We walk when we're carrying something from a countertop to the table. So adding those functional activities, and think about which becomes more complex for people with cerebellum issues, but that's a way to increase the challenge level. And then that sensation, take away or add the sensory input through mirrors, through dimming lights, or whatever the case is, changing the surface on the floor to take away the proprioceptive if the person is at that level. So for Gait, and this is when I'm thinking about this, is as somebody who is lower functioning in rehab, perhaps just got to rehab, is not walking on their own yet. So often practice these transitions. So sit to stand, and step. A low transfer, moving from a surface to a surface without fully standing up. It relates to that degrees of freedom. So this being able to stand up, and it can be, people can hyperextend their hips and their knees, and they overshoot basically and exaggerate these movements. So trying to move with more controlled postures, going from sit to a 3/4 stand and then sit back down, not standing quite up, and see if they can manage that and then sit back down, and then moving into full standing and walking, of course. Starting with shorter steps, and providing visual cues and physical cues. Physical could be your hands, but also could be limiting the space that they're walking through, marks on the ground, so that they're having to control their gait a little bit more. And then progressing often, and starting walking along a stable surface, walking along a wall where there's visual, it's visually safe as well as physically safe, and there's security there, and then move to the open space where they have to cross between the hallway where there is no wall, and practicing that. Think about using, when we're thinking about aids and assistance, certainly try and have as little support as possible, because again, people will grab it and use it if they have it. And gradually increasing your demands. And this just specifically, consider the optic flow. So optic flow is what comes at us and past us. So what we're seeing when we're moving, not just a static movement, but walking, either they're moving or we're moving. So consider what's happening when we're in a therapy environments, what disrupts people's balance, what they can manage, and start to add more difficulty when you're doing that by walking past people, using more open spaces versus a closed gym, that kind of thing. All right, so we're at 5.2. The rest I will go through. Just I was introducing some literature that's coming related to. There's some evidence related to robotic gait training, but it's very early. There's evidence related to auditory cueing, so people may be familiar with that when you're thinking about patients with Parkinson's, but having an auditory cue, whether it's in headphones, seems to actually improve the reduce the variability in the gait pattern. However, this is limited evidence, and it was a single page case study, and it's only present, the effect is only present when the person is receiving the input. So if you take away that sound, then it wasn't lasting for this example. I do want to talk about this light touch strategy. So it relates to that tendency to want to hold, and even for us to want to give people that support, hold the wall bar or hold the railing or the parallel bar. But there's evidence that began in healthy individuals, but that just by touching a surface like a curtain helps us control our postural control. So it reduces sway, it gives us information about where we are in space, and this can be applied to this population. So there was a nice little study called that they referred to the handkerchief intervention. So where there was a single session, a person with ataxia, patients with ataxia walked either on open, where they weren't holding on to anything with just somebody standing by nearby, to walking holding on to a handkerchief that on the other end the caregiver was holding on to. So just like this picture indicates, so there's no real physical support, but the person is getting some information through the handkerchief, it seems. So that this on the left-hand side is the gait pattern, which is with the free walk, and the right-hand side is somebody a healthy control patient, a control participant, and I think I've missed. So basically, sorry, I've covered us up this, but when with the handkerchief walk, this became much more, the basic support narrows, there's less variability, so people were able to manage this walk much more easily with that little bit of touch support. So it's not a long-term solution, but it can be a nice solution to have people sort of wean off of the heavy support of some of the environment that people have that really disables them when they don't have it when they go to their home or go out into the community. The other emerging evidence that there seems to be benefit to brain stimulation. There's two types of brain stimulation, TMS, magnetic stimulation, which is a higher dose brief bursts of treatment, and they put it right over the cerebellum, and there's people end up improving their gait pattern. They walk faster with fewer steps, meaning they took longer steps. So this was a randomized control trial with 2 groups. The other type of stimulation is called direct current stimulation, which is a low voltage but longer period of, so the stimulation was not 60 seconds but 20 minutes, but still over the same spot. And there is also benefit to their arm function. So this is the Ataxia score, but also the 9-hole pegboard test changed. So you see the white is before the intervention, and then the post the simulation, they drop their time to perform the test. Similarly with Gait. On the left hand, these columns are the sham intervention, where they put it on, but they didn't get stimulation. So there seems to be some benefit in this intervention, not only for some of the symptoms, but also for learning. So people seem to learn better after stimulation as well. So not clinically available yet, but it's interesting and maybe something we look at in the future. A couple of things that have really limited evidence: whole body weight vibration or whole body vibration seems to be popular, increasingly popular, but there's not a lot of evidence for it yet. This is a dynamic orthosis, so a suit like a Lycra wetsuit that's specifically sewn to support around the shoulder girdle and the pelvis. And this on this small study improves the gait, but again, it's limited evidence. And that's the Twitter account I mentioned to you that I recommend seeing. So in summary, although this type of stroke is less common than some of the other, like the anterior stroke or the middle cerebral artery, it can be devastating for patients and also challenging for the rehab team. But people can learn and can improve, and our assessment approach builds on our what we already know, but there is benefit to using some of these ataxic specific assessments, as well as ataxic specific treatment approaches on top of our standard task-oriented approach. But as with everything, more research is required, and I know when speaking, we did a survey of clinicians, and this is certainly something that is top of mind for clinicians, although it's not a big part of their caseload. It's always a challenging group, so we need to do more work. So sorry for the rush going through, but any questions?
Thank you, Vince, for the excellent presentation. Does anyone have a question that they'd like to ask, either in the chat, or I can unmute you, or in the Q&A? I've got Amelia Leslie, and I see something in the Q. Oh, and Amelia Boto. So Amelia B says, are there any treatments for the ocular motor deficits?
Yeah. So I'm less familiar with them, Amelia, but there are treatments, and you see them, and often some of the people who actually treat people with vestibular disorders have more expertise in this, and it's incorporated as a core part of their interventions. So in addition to balance training, you would actually train some of the gaze stability and tracking, and over time there seems to be benefit to that. So just like we seem to be able to learn some of the limb control, there's also some benefit to the oculomotor. But
Amelia would like to Amelia would like to answer live, or ask her question live. Sorry, just let me figure out how to do it. We have two other questions. Any benefit of a weighted vest during balance and gait training for truncal ataxia?
Yeah, so I think it's worth trying. The evidence that I'm aware of is less convincing about. I think a weighted vest may be more beneficial than the traditional weighting the limb. It seems that we strengthen those muscles by weighting the limb, but the idea of that intervention was to give sort of sensory input, and but I don't think it's come out as much as well as we thought in terms of some of the studies. But I don't know specifically about the weighted vest, but I think it would be, again, worth trying and monitoring people over time and seeing how they respond to it. The other, I think it was even mentioned in one of the other lectures, the weighting the the walker, which again can be beneficial for some people to give some feedback, but it also might encourage sort of a heavy grip than which maybe we can get people past in terms of that light touch.
Amelia, Leslie, I've unmuted you if you would like to answer your question or ask your question.
Thank you, Barb, and thank you, Vince. Another great talk.
Oh, great. Thank
I
you.
just put my question in the chat. Oh, you're very welcome. So I really like how you mentioned documenting progress along the way with patients. And then I was just curious if you use self-assessments for the patients for them to do that reflection on their own progress.
Yeah, for sure. I didn't talk about any self-assessment tools, but yes, sort of self-perceived abilities. It would be, I incorporate that within their monitoring, because this takes such a long time for some people. It can be, you don't want them to be focusing too much on it, but even to sort of manage expectations in terms of what time scale we're looking at, and but having video examples of that people can watch themselves and see where they were at, but as well as just having them identify some key, like I put their patient specific function scale as one of the tools I use, and it's just a quick, identify 3 things that they have difficulty with, that they want to improve, and rate themselves out of 10 on it, and monitor that over time. And there's other sort of tools related to that.
Thank you. Okay.
Thanks, Amelia. We have a few more questions. You might have given this at the beginning and it was missed by Christine, but can you distinguish between tremor and ataxia? I believe you did talk about that.
Yeah, tremor, when you read, tremor is a component. It's actually hard to tease out sometimes, but tremor would be like, ataxia is often seen as an overarching category of this disordered movement, and tremor being one of the elements of it. So it'd be like, as I described, dysmetria is a component, which is this, this being able to hit a target. Tremor is underlying sort of disorder of movement control, where you're getting, and it can happen again at different, with people with cerebellum, it's the intention tremor, which is coming close to a target, where you get that trying to hit the target, rather than what we see in Parkinson's disease or other conditions. So I think it's best to think about it as a component of the overarching ataxia, or even thinking about it as the cerebellar syndrome, and then these being elements within it. So.
And one last question: what is the role of using weights on limbs or using weighted utensils, etc., for controlling ataxic movements?
Yeah, so as I said, I think there's weights on functional activities like weighted utensils are, some people really depend on them, and they're appropriate to use. I think when I would just say all of these things you can try. The evidence is not, that I'm aware of, isn't strong to support them, but I would do your own little experiment with patients and try them and see, but do it with knowing what you're doing. So add a weight and seeing what's happening with the movement. Can they use that weight in their day-to-day activities? And if it helps them, then that's great. But yeah, just watch. But the evidence isn't strong at the moment that I know of.
I'm seeing lots of messages of thank you for the great talk in the chat. We will have to wrap up now. We went a few minutes over, which I love when there's great discussion. Thank you, Vince, Dr. DePaul, for doing yet another presentation for us at Central South Regional Stroke. You thought you moved out of our region, but we keep pulling you back. So thank you for that. And it's such an easy commute with our Zoom presentations.
That's right.
I really appreciate that you were able to talk about so much intervention, and I think our audience appreciated that as well. I would love it if the attendees would complete our evaluation. That helps us know if we're on the right track and what else you'd like to hear about. And thank you, Vince, for agreeing to let us record this session. I'll have it up on our YouTube channel and or our website later today. And I'll send you a link tomorrow, everyone, just to remind you where it is. And hopefully I'll be posting Vince's handout as well, because he did agree, and I've recorded it, that he would.
I will send it. It's if I need to, we can share it by Dropbox or something like that if it's too big, but I'll try and send it.
We'll find a way.
Yeah.
So thank you once again. It was a great end to our 6-part series, and you got to be the finale. So thank you for that. And Vince is sharing his email address, and willing to answer your questions that way. So that's amazing.
Yeah, that'd be great. So thank you. And it's always fun. And if people do want to reach out, certainly I'd love to chat, or if you're thinking about a clinical research question that you'd like to try and explore, whatever the case is. So yeah, it's always nice to talk to other clinicians. So thank you.
Well, thank you, Vince, and thank you everyone for attending. And you can enjoy the video shortly and tell your friends. Right. Thank you, everyone. Thank you, Vince.
Bye.
Have a good day.
Too.